So the evidence is saying the brain is primed to recover. So the brain wants to get better. I always describe it as kind of the use it or lose it principle. So you want the person to start moving the affected part. You want the person to get moving. If you don't move, you're not going to get better. The idea is also greater intensity. So the more the person gets, the more therapy the person gets, the more connections the brain connections, the better they're going to do. So the more therapy we can get them. So the clinical association is earlier admission to rehab, and giving them a lot of rehab near the beginning is better than giving them a little bit of rehab over a long period of time. Except maybe the more severe strokes, they might need more time to improve. So when you see the benefits behind in stroke recovery, the first part we talked about already is natural recovery. So with the natural recovery, we talked about how quickly improvement will occur. Also we'll look at reduction of swelling, reduction of bleeding. That's why people will do better. So without even any therapy, just even that change in the brain itself, people will do better. The brain plasticity. You want to increase the connections within the brain for people to do better. So sometimes when you get a recovery, other parts of the brain will take over. So if there's a stroke, there's damage done at one area of the brain, other areas around the brain will take over for that loss of function. So as an example, let's say the arm, you got weakness in the arm, and so there's damage right at that area in the brain. But the nerves around it may take over, and the person may still get recovery in the arm, not because that spot's healed itself, it's just the brain is actually able to make changes and make improvements. And with rehabilitation, mental imagery is an area now that they look at where if the person rehearses or thinks about an activity they can't do, will get improvements. So I would put down downtime. So when a person's lying in bed waiting for rehab to come to them, or they're not sure what to do, if the person can practice in their mind something that they with the affected part. So example, let's say the leg's paralyzed and they can't walk. If they can practice in their brain the idea of walking, see themselves walk, the nerves are still functioning in the brain. You might not see movements in your legs, but the brain actually is still working. And if you can get that part started, that's part of the idea of recovery. So I'm always telling the patients, if they want to get better faster, you got to start practicing. Or same thing if you're like throwing a ball and your right arm's affected, you're right-handed, think in your mind how you would throw a ball. And these are the kind of things that makes it better for therapists. So when you see the person, when therapists see them, they're better able to improve in rehab. So practice repetition, a lot of rehab is that, where they get you to do the same activities over and over again. You're learning things. And sometimes you're functionally learning to do something differently. So the person may have weakness in the leg when walking. So the therapist may work with the person, and they may get them to, it may change their walking a little bit. Or if their arm, let's say they're right-handed and their right arm is weak, they learn to use their left arm. Okay, so part of the recovery, functional recovery, they're still weak on the one side, but they've learned to do something with one hand. Or they can learn to tie their shoes with one hand. They learn to get dressed with one hand. Okay, and that's the functioning. So you're still getting improvements. You might not see any strength improvements, but the person's still making changes. Okay, some of these are the various things of what kind of the areas that are interest for rehab. What's called constraint-induced therapy. I italize forcing and restraining because ethically that's probably not the best words to use. But forcing the use of the affected limb by restraining the unaffected side. Okay, so if you have a stroke and your right side is weak, your left side's working fine, you want to basically tie the person's hand behind the back is kind of the theory behind it. So what I put down is using a glove on the good side. You can put a glove on, sometimes you can wrap the hand like an oven mitt or something like that. You can put that on. Or put your hand in your pocket. And it only works if the person already has some isolated, or already has some wrist and hand movements. Okay, so if the person has very gross weakness and they only can just lift their arm like this, they're probably not going to do very well with constraint-induced therapy. But if the person has some isolated movements, you tell the person, well, you should feed yourself with your left hand, or you should pick up the phone with your left hand, or whatever activities you need to do. And the studies have been done where they've used things like using an old adding machine, or dialing a phone and picking up the phone. And what they did is they had the same person do this activity over and over again for hours and hours on the day. And they found that those individuals did better than other individuals in therapy because they kept practicing the same activity. So whenever you see someone with weakness on a side, you're always reassuring, telling them they've got to practice using that one side. They've got to keep using the arm. Try to avoid using the good side. Ethically, from a research point of view, it's sometimes difficult to do this. To get an ethics board to approve some of these studies. I mean, these studies have been done, but it's difficult to do. The therapist may try to do this, but they'll do it in a nice way. Virtual rehab. That's a big thing that's coming on now is virtual rehab. So people who use Wii, Xbox, there's evidence that improves recovery from a stroke. So green screen technology that we have here at Hotel du Shaver, the whole idea of working on balance and motor recovery and coordination, And just to show you, there's an international conference on virtual rehab in 2011 in Zurich. So if Jane wants to send me there, I'm willing to go. It's become a big thing now, is virtual rehab. I mean, you got a whole conference now, international conference now. So this is a little bit on robotics as well. But the whole idea is that this has become, it's going from a little field to a big field now. And I think it shows rehab can be fun. Those who have used it, it's kind of a different idea than on just doing some of the traditional therapy. If anyone's ever done it, it's a lot of fun. Alternative therapies. A lot of people say, you know, I've gone through all this stuff before and, you know, I've still got problems. What about this or what about that? So I've just touched on a few of them here. Acupuncture. So that's where you put the little needles. I don't know if anyone's had acupuncture. It does work sometimes for pain-wise. But from a stroke point of view, they say conflicting evidence, which means they're not really sure. Okay? There's not really much proof saying yes or no, but improving ability to look after yourself, enhancing motor recovery, reducing spasticity. There's not good evidence from the literature right now saying that acupuncture will do that, though some people may say it works for them. But overall, from someone to say, yes, you should do this for treatment, there's not enough evidence to support this. Aromatherapy, so aromatic compounds to alter a person's cognition, function, or health. This is modern evidence that with acupressure reduces painful shoulder. So acupressure is basically finding tender points, particularly, and putting pressure on these areas. And you can reduce pain. And I don't know how and why they did this, but why someone would do aromatherapy and acupressure at the same time, I have no idea. But just to show you that there are other things out there that sometimes will reduce some symptoms. Hyperbaric oxygen, a lot of people talk about this. From the studies that have been done, it's a strong evidence, which means doesn't sound good, that does not improve neurological status. Okay, so if someone's had a stroke and they say they go some places and they get oxygen, again, I'm not saying some people do this, that's fine, but from an evidence research point of view, it doesn't work. Now, maybe if the person had hyperbaric oxygen right when they had their stroke, maybe the person would do better, but there's no studies that say that. So these are people who have had stroke a number of years or a number of months or years after their stroke. It doesn't work. Massage therapy, the modern evidence that reduces pain and anxiety, makes sense. Music therapy, so there's limited evidence that improves depression, makes sense. Maybe I think it's music, maybe it's if you like the music, it works. If you don't like the music, it probably doesn't help. Reiki treatment, which is palm healing, it says modern evidence, which basically is it doesn't improve functional outcomes, it doesn't help. Tai Chi, this is one of my favorite exercises for after stroke. It's a Chinese system of physical exercise for self-defense and meditation. I describe it as a sequence of slow and fluent movements. Proposed benefits, relaxation, motor recovery, because it encourages you to use the affected side and helps with balance. The last guy here is trying to do a little bit of Tai Chi. That'd be me doing Tai Chi, I think. If you have weakness in an arm, in particular if you have coordination problems with an arm, I really think Tai Chi, there's not a lot of great evidence behind it, but again, Tai Chi encourages the person to do more fluent movements. And I have a number of examples of patients who have done that, and it's made a big difference. I'm not going to give you names, but it does help. So this some just shows you sometimes the evidence isn't there. Some people are still going to encourage it. It's a difficult area to really test. So from the medical point of view, we're looking at rehab. When someone's had a stroke, you're looking at trying to prevent complications. Okay, so of course, you know, diabetes, high blood pressure, you can look after that. You're going to prevent complications. You want the person moving around. You want to make sure they're not swallowing the right diet. They're not taking liquids inappropriately. So you want to prevent complications like pneumonia. Constipation, big problem. People aren't moving around. They get constipated. It can lead to like surgery. It can lead to rupture. Person doesn't want to do therapy if they can't go to the washroom. Blood clots. You get blood clots in your legs. That can travel up and cause another stroke. Or can go to your lungs and cause pulmonary emboli. Again, things you want to prevent from a stroke. So you want to maximize recovery. So things that are common after stroke is spasticity, which is velocity-dependent increase in movements, resistance to movements. So normally in a stroke, you see some individuals with a stroke where their arm might be in this position. That's increased spasticity or muscle tone. And there's evidence that therapy, of course, will reduce that. Some medications help. One of the things mostly now is the Botox, which Dr. Khan at the back does Botox locally in Niagara. And evidence that it works in decreasing spasticity, improves function, might have some reduction in pain. Some people have braces that they use maybe in their feet, but with Botox you might be able to reduce some of the tone and get the person away from using braces. So that's a talk in itself, and maybe Dr. Khan will do a talk one day on Botox. Depression, if an individual is down, after stroke, they're not going to feel like doing rehab. They're not going to do as well. Evidence shows that if you give a person an antidepressant after stroke who is down, they will do better than someone who doesn't have an antidepressant. It doesn't mean they're clinically depressed. I'm a physiatrist, not a psychiatrist, so I can't diagnose depression. But if they have the depressions, you know, they have the symptoms, no energy, they got, you know, the crying inappropriately, a lot of those problems. If you put them on an antidepressant like citalopram, they'll make differences and they'll improve their rehab. Pain, of course, pain is very common after stroke. That's very important to be addressed by the team on reducing that. I'm almost finished. Medications. When you look at treatment particularly, you're always looking at prevention. Primary prevention from a medical point of view, there are no pills that will prevent a stroke from happening from the first place. Okay? If you've never had a stroke before, there's really no medications that will prevent a stroke. I mean, if you have atrial fibrillation and you're on Coumadin, that will work from preventing a first stroke. But from an idea of just, you know, if you have heart disease or diabetes, there's no evidence that any medications, particularly like an aspirin a day, will prevent a stroke. It's more of a secondary prevention. So once someone's had a stroke, then there's evidence that these medications will reduce a second stroke. Okay, so when they've had a first stroke, it'll prevent us from having a second stroke. So acetylsalicylic acid, so aspirin, Agranox, or dipyridamole, clopidogrel, warfarin. Sometimes these people will be on those medications, and the goal of that medication is so the person doesn't have a second stroke. If the person has a hemorrhagic stroke, which we talked about, that 20%, those individuals are to avoid blood thinners. So they're to avoid those medications and maybe even anti-inflammatories as well. The reason why is those individuals, if they are to have a second stroke, they're more likely to have a bleeding stroke. So if you're already on a blood thinner, you can have a bigger stroke. Now, the question, it always becomes difficult if the person has heart disease and heart problems and they have a bleeding stroke, because sometimes the cardiologist will want them to take a baby aspirin. It's an individual basis. A lot of time with treatment for a stroke, somebody else may do this, somebody else may do this. It's really one-on-one. It's what your doctor decides. This is just for kind of education. So last little bit is just getting on with your life. Okay, so when someone's had a stroke, they finish rehab, these are some common questions or difficulties that people have and that often will come to myself and ask these things. So exercise, you know, how much exercise should I do? You know, do I need to keep going for therapy all the time? A lot of the time is, depending on what degree of stroke, how much weakness you have, sometimes just doing your daily activities, working on dressing, bathing, transferring, sometimes is exercise in itself. Those who are able to do more than that, a lot of the therapists will teach people home programs. Or if you leave the hospital, you have a home program. So these are exercises, so there might be stretches to do, or they might tell you people to walk frequently. Some people will go join the gym. Some people will go to the YMCA. There's a discount on memberships for people who've had a brain injury going to the YMCA. So a lot of people will go to the Y and have a program developed there. And all you need to do is you get your doctor to sign a form. And I've signed enough of those, so I know about that. Work-wise, a lot of people are older when they have a stroke, so work is often not a big problem. But unfortunately, there's a lot of younger people having strokes, and this is a big problem. Going back to work is going to be dependent on your physical function and your thinking function, your cognitive function. Of course, if someone's more impaired, they're going to have more difficulty going back to work. But if those things are out of the way, then also, like I said, with age, the younger person is more likely to go back to work. Their education, maybe the more highly educated person, depending on what job they do. I mean, if you have a stroke and you work on some very assembly line, it might be harder to go back to work versus working more administrative or office work. And in what job you do. Driving is a big thing. By law, if someone has a stroke and it is felt by the team and the doctor that it would affect your ability to drive, by law you're supposed to send a note to the ministry to notify them that they've had a stroke. The doctor just sends a note to notify that it's happened. The doctor does not suspend your license. The ministry does that. I always pass the buck to the ministry. It's not my fault. So often what they're recommending is more of a two-step process, and that's what happens in Niagara Rehab when they come for therapy. Is the first thing you look at more of the screening. So a lot of people here have gone through a lot of tests. They're called the trail A's and B tests. There's a visual motor perceptual test, or MVPT, and there's all these tests that the therapists do. Winnie and Christine, etc., will do these tests, and a lot of people say, why am I doing these tests? The idea is it's trying to give people an idea whether based on the results of those tests, how safe the person is going to be back driving. Okay? It gives you an idea, because if you need to go for a driving test, it's like $500 or more. It's quite costly. People don't have the money. And I don't want people to go for a test and fail it inappropriately. So what we try to do is you try to screen the people out. The people that you know will do well, you might send a note to the ministry and the person gets their license back. The people that are iffy, those people might have to have a test. The people that are doing poorly, you're going to tell them you're doing poorly, and it's not a good idea to go for a driving test because you're just wasting your money.